Good morning. Thank you very much for the invitation. Indeed, it is always a great pleasure to be here. Today I would like to discuss with you not really the treatment of acute heart failure, which was so nicely and elegantly discussed by Professor Philippatos, but rather to give you the future directions. This is my disclosure. Let me briefly summarize the topic for you today. I would like to give you a very brief summary of some recent disappointments we have been seeing in the treatment of acute heart failure syndrome. However, mainly I would like to discuss with you what would be the outlook for the nearest future. I truly believe that we need to be ready for the concept of profiling and strategizing the care in acute heart failure at all stages of this disease, of the disease management. I would like to discuss with you the results of a recent trial and to strengthen the concept that we still are happy to welcome new trials which prove the concept, hopefully, that early short-term intervention would affect the long-term outcomes. And last but not least, to discuss this peri-discharge period, which in my opinion is one of the most important part in the whole management. Gerasimos very elegantly told you about how important is acute heart failure. This slide shows you actually that this is a specific entity in the natural course of chronic heart failure. This is the population of stable patients recruited for the MADIT CRT, asymptomatic class 1 or early 2, NEHA class. If you see here, those who decompensated, regardless of being treated in the outpatient or inpatient circumstances, they tended to have a dramatically bad outcome. There, how to use the mouse? Here is the mouse? No. I'm sorry. So those who, thank you. Those who decompensated tended to have a mortality 20 times higher than those who were stable. So we really need to keep this in mind. The landscape for the beginning of the 21st century is actually summarized here. Gerasimos very elegantly referred to the recent papers showing that those with acute heart failure, they tended to have a very high mortality and morbidity. And last but not least, we need to remember what we wrote some years ago, that broadly speaking, our armamentarium is very limited, consisting of loop diuretics, vasodilators, and inotropes, and talking about the future is always very challenging. Why it is so difficult to treat heart failure? It is because there are a lot of different clinical factors. As you see, different underlying causes, different clinical presentations, and I really believe this is the crucial story, and we will be discussing this further, that we need to adjust the treatment according to the clinical presentation. In other words, one size would never fit all. The natural course is always complicated by cardiovascular and non-cardiovascular comorbidities. As Gerasimos said, the pathophysiological targets are still unclear, and we are very uncertain what should be the target. And last but not least, we have not clearly defined the endpoints. If we look at those treatments we are using in everyday clinical practice, we see that they are targeting the at least well-perceived and well-defined pathophysiologies. They alleviate congestion, they reduce increased filling pressures, and inotropes, they do very well to improve the hypoperfusion. So this traditional therapeutic approach is actually targeting what we truly believe are the pathophysiological mechanisms, but if we see the effects of these treatments on the long-term outcomes, some of them may even be detrimental. And this is a very clear dissociation between symptomatic improvement, clinical stabilization, and potential favorable long-term outcomes. And this is the future for us. we need to translate the acute heart failure successes or stabilization into the long-term outcome. The recent acute heart failure trials have not been very successful, and only for your perusal today, I highlighted 3 morbidity trials. I highlighted Ascend, Everest, and Protect. And as you see, despite, again, targeting baseline mechanisms, despite recruiting thousands of acute heart failure patients, they simply failed. They simply failed to produce the long-term outcomes in these vulnerable populations. So we are a little bit disappointed indeed. And this is, I truly believe, that for the future, for the proper outlook, for the nearest future, because we can't really predict what is going to happen in the next 40, 50 years, say the next 5, 10 years, I would like to start proposing you the new approach based on profiling and strategizing the care at each stage. Gerasimos already introduced the concept of 3 phases of heart failure management, which I like very much, and we are promoting this. This is initial, in-hospital, and peri-discharge phase. And we have here very clear clinical tasks. We need to define the goals and, as I say, characterize patient's clinical profile. We may argue, but I truly believe that adjusting therapy for clinical profiles is really important. At the initial stage, this is really fundamental to find out life-threatening conditions. In other words, profile, characterize the patient initial clinical profiles on admission using these 5, proposed by ESC, 5 life-threatening potential scenarios. This is going to be impaired ventilation, life-threatening arrhythmias, cardiogenic shock, acute coronary syndrome, and acute mechanical disorders. This gives us this patient character, life-threatening conditions, and proper characterization would give us a hint what to do next. Then we have this profiling at the early stage, not at this life-threatening, but early stage. This is the division, the summary of clinical characteristics I have borrowed from Gerasimos. In the center is what we all truly believe is a major and the key issue for all patients admitted with acute heart failure, pulmonary edema, but as you see here, there are many others. I truly believe that hemodynamic profiling gives us a hint where to go. As you know well, this hemodynamic profiling is based on a very simple approach. Is this enough perfusion? Is the patient warm or cold? Or is there congestion? Having these clinical profiles, we can say if we have a warm and wet scenario, which is the most common and the most typical, like pulmonary edema, we are simply trying to dry out the patient. We will be discussing how. However, if we have this unfavorable scenario with very cold and wet patients, which is most challenging, we would go for first warming them up and drying out. This is a little bit simplistic, but I believe it may work very well in clinical practice. Then we have this peri-discharge phase, when again, profiling and categorizing patients is very important. Clinical profile would affect management strategy, and we need to take into consideration several important elements. The first one is whether patient is doing well, whether there is no in-hospital worsening. The second is underlying etiology. The next one, already mentioned by Gerasimos, is what about comorbidities? The next problem is what about potential candidates for device therapy? And last but not least, how to identify those who are at very high risk in their post-discharge follow-up. This is the concept we discussed for the last couple of years, and we now truly believe that it is valid and it needs to be taken into consideration for the future trials. This is a concept of in-hospital worsening. We all believe that the clinical natural course of acute heart failure always goes like this, smoothly and nicely from the beginning to the end. In all these clinical trials, when we plan these clinical trials, we now know that after clinical stabilization, there may be some sort of a failure, and we call this in-hospital heart failure worsening. Our understanding and our profiling and also potential implication of novel therapies should be based on this clinical characterization. We have the data from the RELAX trial where we observed that across the whole hospital stay during heart failure management, acute heart failure management, serelaxin hugely reduced the risk of in-hospital worsening by around 50%. This is why we came up with the concept, and this is the slide I have adapted from Milton Packer. Then in-hospital worsening represents a meaningful change in clinical status. It needs to be a part of the clinical characterization. Therapy needs to be adjusted towards the occurrence of in-hospital worsening. In-hospital worsening is always related to end organ damage, finally unfavorably affecting the outcome. The next part of this outlook for the nearest future is based on the concept that early short-term intervention can affect the long-term outcome. We have been seeing this in acute coronary syndromes. Early intervention in acute coronary syndrome like thrombolysis or PCI would improve mortality and morbidity. We haven't that sort of a very positive approach in our acute heart failure patients. I think that now we are really ready for the paradigm shift. We think that there are several conditions which needs to be fulfilled. We asked ourselves what is needed to impose that sort of treatment in early phase which would have favorable consequences in the long-term run. As I said, we need targeted approach, so we need a careful clinical characteristics because different pathophysiologies, different clinical conditions, they would require different approaches. We obviously need to have an ideal drug. We need to debate what ideal drug really means, but drug targeting substantial and important pathophysiologies as well. And last but not least, I am happy to say that we are ready to test the concept, the earlier the better. This is another story, I would say important, not prospectively validated, yes, but everyone who is dealing with acute heart coronary syndrome believes that the earlier the patient is sent for the cath lab, the better. In acute heart failure, this does not work. Nobody cares to treat aggressively those who are short of breath. We need to change this strategy, and I really mean what I say. We discussed the issue of decongestion. Here again, decongestion, as Gerasimos showed you this beautiful picture of two different types of patient. One is with volume overload, and one is with shift of the volume. And this is why we need to, in our approach to the treatment, we need to differentiate pathophysiologies, and congestion is the most important and a valid therapeutic target. As you see here, we can have a very fast pathway for congestion, and for this vasodilation or some other interventions may well be what we want. And the second one, which is slow, which is simply volume overload, and this is for diuretics. What about prevention of end organ damage? This is what we have recently added to our understanding of different pathophysiologies and different treatment. Gerasimos very elegantly already started showing you that in the RELAX trial with serelaxin, we have a very first evidence that reducing the risk with serelaxin of end organ damage, as evidenced by less troponin leak, less renal damage, less hepatic damage, we would probably have the positive outcome. This is the final slide in this part, showing that indeed the early intervention can prolong life. This is the summary of pre-relax and relax trial in which we both, myself and Gerasimos, were involved. And it clearly shows that this treatment reduced the risk of all-cause mortality and cardiovascular mortality significantly during 180 days follow-up. And this is why we are testing this in the ongoing trials. But for your perusal, I would like to now compare serelaxin with diuretic nitrates, nitropes, showing that actually what you see here, the serelaxin benefits and serelaxin potential adverse events are different, favoring this kind of approach versus both nitrates and diuretics, and also inotropes, which are now recommended only for very selected group of patients. As I already mentioned, there are two trials, two new ongoing trials. RELAX aimed to recruit more than 6,000 patients, and TRUE-HF with ularitide. More or less the same approach. As you see here, the earlier the better strategy imposed, treatment starting within the first hour, 16 in the RELAX and 12 in TRUE-HF. For those of you who are not familiar with ularitide, I can only tell you that ularitide is a naturally occurring, is a form of natural occurring the dilating hormone, which is similar to ANP, having hemodynamic, bronchodilative, neurohormonal, and favorable renal effects. And this is another compound tested in the TRUE-HF trial. Last but not least, for the 3 remaining minutes, I am going to discuss this part, which I really believe is very important. This is the part we simply do not pay attention. This is the part when the patient is already stable and ready to go home. Typically, in the United States, the whole acute heart failure management in the hospital takes 3-4 days. You can't really focus on this important intermediate and pre-discharge phase and follow the patients in a proper way. You can't. You can't really consider all these important goals defined on this slide, like maintaining stabilization, initiation and up-titrating optimal therapies, and several others, simply because you don't have time. I'm not saying that we would keep our patients for several weeks in the hospital. I'm saying that during these 7-8 days, we need to consider these elements as an important part of the therapy. I'm going only to focus on these two. As you know very well, this is the best timing to initiate and up-titrate the treatments. This is the summary from beta blockers history, showing that those who tended to be treated with beta blocker, they tended to do quite well. The worst case scenario is to have a patient on beta blocker, withdraw the therapy and not initiate this. I am very glad that we have 20 minutes discussion, because we have the new compound. Gerasimos already started discussing about, and we have Professor Svedberg, who is a member of the executive committee of the trial. We have a new compound, very active. This is the summary of the effect of the drug on the all causes of death. You see that this is an extremely important part. Sudden death is also reduced. So when to start the treatment? This therapy was started in a stable phase. Can we start this as well in the acute stabilized patients? As you see here, the new treatment hugely reduces not only the proportion of patients, but also the number of hospital admissions, very importantly. A new idea we came up with, and also Gerasimos is involved, the idea of iron deficiency. Patients admitted with heart failure decompensation, half of them are having iron deficiency. We are very close to propose the concept that this metabolic intervention, which is inevitably linked with very poor outcome, is going to be something additional. This is a new concept. This is not hemodynamic. This is not in the very early stage. This is in the peri-discharge phase to optimize the metabolic profile during the post-discharge period. Last but not least, I am going to show you that this post-discharge phase is extremely vulnerable for the patients. We as physicians dealing with these patients are sending them home, and we are happy. They are stable, they are well treated, we believe, and they are discharged home. During the first 3 months of this post-discharge period, regardless of the stay in the hospital, the risk of death was dramatically high. And my last slide, which is actually something wrong here, maybe now, okay, which is actually the summary. I think that indeed we are looking forward not necessarily novel drugs. We believe that we would have many in the, oh, not many, some, but efficient. But we are going to prepare a new strategy in order to improve the in-hospital and long-term outcome of our patients. Thank you very much.